Okay, so today we'll talk about some details about evaluating coronary arteries with CT, and then I'll talk about the CAD-RADS 2 scoring system, which is relatively new. Not that I expect you guys to learn it or memorize it, but I will talk about the parts of it that are important to know that can be fair game as far as exam questions. Okay, so if we look at a case like this, and I ask you what vessel are we looking at? Are there any lesions, and do you have any recommendations? What do you guys have to say? What vessel are we looking at?
LED.
Look at the LED. Are there any lesions?
Yeah.
Yeah. So what do you see? You see a
Proximal.
yeah. So we see a calcified plaque here. Okay. How much stenosis?
70 or 30% stenosis, like 70% of the vessel
I
is
don't
open.
know. That's not. Yeah. I mean, so it's maybe 25 or so. But do we recommend another imaging study here? Yes or no?
No.
No, that's the point. So here you would not recommend any further follow-up, okay? Now what about this one? What vessel are we looking at here?
RCA,
Now we're looking at the RCA. How much stenosis?
greater
than 70%.
75%.
Well, it's greater, yeah, it's definitely greater than 70%, so this would be characterized as a more severe stenosis. So here, what's the recommendation?
Angiogram, catheter angiogram.
Yeah, so here your recommendation might be invasive coronary angiography, okay? And then that is a severe stenosis there. You could see it on the volume rendered views, although you should not use those really for looking at coronary arteries. But so here you go, severe stenosis of the right coronary artery. What about this one? So there is a lesion. What's the percent stenosis? Maybe 50, maybe a little more, but certainly not greater than 70, right? So what's the recommendation here? What do we do here? What?
Cardiac perfusion without nuclear perfusion.
So here the recommendation might be to do a functional study because you don't know for sure whether this degree of stenosis is physiologically significant or not. All right, and that's the point about this, about CAD-RADS 2. So what are these scoring systems about? I mean, we have them all over in radiology. They're about standardizing the way we report the various studies. It's to facilitate communication with referring physicians, right? They don't want to hear about all the details and everything. They just want to hear what's the final score. What's the conclusion? Because this part is really important. The score gives you suggestions for patient management. So the scoring itself is important. That's true in all of these scoring systems that we use, whether it's lung RADS or liver, or thyroid, whatever, is that there are suggestions for patient management there. Okay, now there are downsides of imposing these scoring systems also because it gives everybody tunnel vision, right? And then it forces this paradigm on you in terms of how you are supposed to look at these studies, okay? But this is the standardization that everybody seems to want to do, right? The framework for the scoring system when we're looking at coronary CTA, stenosis, we're trying to find the most severe stenosis. Plaque burden, this they have added to the new scoring system to 2, it wasn't there on 1. And then there are these various modifiers. They have a modifier for ischemia, and which can be from CT-FFR, fractional flow reserve, which we will talk about, we'll explain what that is, or myocardial CT perfusion if you happen to do myocardial CT perfusion. This you have to know. This is a fair exam question, right? Grading of stenosis. So we don't try to give an exact number. We don't give a number like 22%, 72.5. We put them in ranges, and these ranges you have to know, right? So minimal is less than 25%, mild 25 to 49%, moderate 50 to 69%, severe 70 to 99%. So when you're looking at a stenosis, you have to put it in one of these categories because that's going to determine the score and eventually the management about what you're going to recommend for the patient. And a score of 5 is completely occluded. Okay. Now they've also introduced in the new scoring system, you're supposed to assess the plaque burden, right? So now there's an easy way to do it is to just use the coronary calcium score. Okay, and they give you the coronary calcium scores, and then you can assign these modifiers as far as plaque burden going from mild to very extensive. Or you can actually look yourself at the separate vessels if you don't have the calcium score to visually assess it, but that's much more difficult. Very simple just to use the calcium score. I'm not going to test you on this, okay, but just realize that this is there, that there is an assessment also for the amount of plaque, and that's pretty easy to do with the coronary calcium score. And then what we're supposed to do is judge the highest grade stenosis. We're supposed to look at all vessels greater than 1.5 centimeters in diameter. And then there are these various modifiers that are in the scoring system and for non-diagnostic high-risk plaque. We'll talk about what that is. If you have any information on ischemia, if you've done CT fractional flow reserve, if there is a stent, if there's a graft, and they've introduced this exception. In other words, are there other non-coronary atherosclerotic related lesions, right? So is there an AV fistula? Is there a coronary aneurysm? Is there an anomalous origin of a coronary artery? So that allows you to discuss that too in the scoring system. So the various modifiers, I've given you the list of it. We'll go through them pretty briefly, okay? And for non-diagnostic study, it's for some reason, there's motion, there's blurring of vessels, you cannot evaluate all of the vessels, then you would use this modifier N, alerting the physician, hey, we haven't been able to evaluate all the vessels adequately, so we can't rule out that there might be a lesion that we're not evaluating. However, if there is a stenosis greater than 50% somewhere else, so let's say in the LAD you find a stenosis greater than 50%, but you can't evaluate the right coronary artery because of motion, you would still add the N modifier, but you would grade the actionable stenosis, right? If there's a stenosis greater than 50%, that does affect your management. So you would include that in the scoring system. So in other words, you don't throw out the whole exam just because you can't evaluate the right coronary artery. If you are able to find an actionable lesion somewhere else. Okay. So if I ask this question, what type of calcification is considered a feature of high-risk plaque? So who's out there? Anybody at St. Barnabas? Yes? Okay. So what type of calcification, or which of these is considered a feature of high-risk plaque? So I have a spotty calcification, a medium-sized calcification, and a coarse calcification. Which one of these? No. Spotty calcification, right. That's a feature of high-risk plaque. So anybody at Beth Israel? Yes? No? Okay, you guys over here. You are there at Beth Israel? Come on, you got to jump in there. All right, high-risk plaque, attenuation below what cutoff value? What's the magic number?
30, I'm guessing.
30 is the magic. Don't say I'm guessing when you get the answer right, then you get no credit for it. 30 is the correct answer, yes. So that is a critical number. That's also a feature of high-risk plaque, an attenuation less than 30, so that implies that it may be lipid-rich, that it may be more unstable. Okay, so the different types of calcification, we can have, of course, a non-calcified plaque, you can have a calcified plaque, you can have spotty calcification or coarse calcification. The spotty calcification is a feature of a high-risk plaque. So this is a fair question. What are features of high-risk plaque? And we'll talk about what these mean. Positive remodeling, low attenuation core, spotty calcification, napkin iridium sign. These you definitely should know because these are listed in the scoring system. These are a little bit more unusual if there's ulceration, inflammation, or hemorrhage. But it is a fair exam question to ask you what's a feature of a high-risk plaque. So that's where they have this modifier for high-risk plaque, HRP. So spotty calcification, if you have small dots of calcification like that. Napkin ring sign, if you have this low attenuation region in the plaque surrounded by a higher attenuation region, this is supposed to be more unstable. Positive remodeling, meaning that if the vessel seems to dilate, where you have the plaque, because the plaque is growing in the wall and causing the vessel to actually get bigger in diameter, and low attenuation, if it is less than 30 Hounsfield units of attenuation, if you measure it less than 30, those are all features of high-risk plaque, okay? So let's kind of go over what these are. We've talked about spotty calcification, these little dotty areas of calcification, that's spotty calcification. Napkin ring sign, if you have a region of low attenuation within the plaque, see that surrounded by this hot region of higher attenuation around it, that's a napkin ring sign, so that is an indication of a high risk. That's a high risk feature, okay? So if we're actually going through the grading here for, here's an example of another high-risk plaque. There's mild stenosis of the right coronary artery here, so this would be graded as a 2, P2, but what are the features that make it high risk? The attenuation here is lower than 30, and there's positive remodeling, meaning that this part of the vessel, when you measure it from here to here, is more dilated than it is more proximally or more distally, right? So that's positive remodeling. That's also a feature of a high-risk plaque. If you happen to see ulceration within a plaque, that's also a high-risk feature, although that's pretty rare to actually demonstrate on CT. There is a grading scale too if you happen to do fractional flow reserve with your CT scan, and we'll talk about what that means, but there are these values for fractional flow reserve that give you an indication of ischemia. And that also you can indicate in the score. And a little bit later on in the lecture, we'll talk about this and what these numbers mean as far as fractional flow reserve. And then we have these modifiers for exceptions, meaning that if there are any of these, there can be any other abnormality of a coronary artery not necessarily related to coronary atherosclerosis. So any of these things, of course, you're also going to indicate in your report. If we have aneurysms, if there's AV fistula, right, anything else that you might see. This is important. This is something that you need to know, okay? In terms of the management, if the stenosis, the grade of the stenosis is mild or less, up to 49%, so that is considered non-obstructive disease. So these patients usually do not require any further imaging workup, okay? If you have a stenosis in this range, between 30 and 69, considered moderate, this is potentially obstructive. So this will require further evaluation. We can do studies looking for ischemia, functional assessment, okay, here. If you have a severe stenosis, grade 4, 4A or 4B, whether it's through triple vessel disease, makes it 4B. If the left main coronary artery is involved, greater than 50%, that's also a 4B lesion. So here we're talking about obstructive disease. For 4A, it could be invasive coronary angiography or function. For 4B, invasive coronary angiography is recommended. And if you have a completely occluded lesion, a complete occlusion or what looks like a complete occlusion on CT, you might suggest invasive coronary angiography or a viability study, in other words, an MR or something, or a PET, to see if there is viable myocardium there, because if there has been an infarction and you don't have enough viable myocardium, then it's not worth revascularizing, okay? So this is something you need to be familiar with. In terms of functional assessment, what are the studies that can be used for functional assessment? There's fractional flow reserve, CT perfusion, exercise, stress test, stress echo, all of these might be usable as far as evaluating for function, okay? And then with cardiac cath, they can also do an invasive fractional flow reserve measurement, which we'll talk about. Also. So the bottom line, if you have up to mild stenosis, or then preventive therapies, these do not require further workup in terms of the coronary artery disease. If you have moderate stenosis, then once we're above that, then we do need to consider further testing. And if we're talking about moderate stenosis, usually we're talking about functional testing or some kind of stress test. If we have severe stenosis, then you think about invasive coronary angiography, although you do have a choice with 4A lesions to do stress or invasive coronary angiography. So the degree of stenosis does affect the management or your management recommendations for these lesions. Now, I've given you all this in your handout. Again, you don't need to memorize this. This part is not something I'm going to test you on in terms of all these granular recommendations that they make for the complete scoring system, but realize that this is there. So this is for stable chest pain. We have all these recommendations, but there's also recommendations for patients who have acute chest pain. In other words, a patient in the emergency room who shows up with acute chest pain, you do a coronary CTA, And then you grade the stenosis. Well, we also have recommendations for what we're going to do in those cases also. So the scoring system also supplies that for acute chest pain. Okay? So the best you can do is CAD-RADS 0, right? You have no stenosis anywhere, right? So, and no plaques, nothing there. Okay, so that's good. And then here's an example of a CAD-RADS 1 where we have minimal non-obstructive stenosis 1 to 24% and a mild plaque burden. You might have some positive remodeling, but the stenosis is really not significant at all. This is an example of a CAD-RADS 2, mild non-obstructive stenosis. Here we're between 25 and 49%, so we're still less than 50%. Moderate plaque burden, again, this is not going to require further workup, even though this patient did get an angiogram there. And then if you have a 3, moderate stenosis, 50 to 69%, so mild plaque burden in this case, so this will require some kind of further evaluation, usually functional assessment. And then when we get into the 4s, severe stenosis, here if it's a 4A, you can consider invasive coronary angiography or functional evaluation. A 4B, where you have triple vessel disease, there invasive coronary angiography is recommended. And the other thing to remember, because this also is a fair exam question, stenosis in the left main coronary artery. If you have greater than 50%, so the left main is different than the others, if you have greater than 50% of the left main coronary artery, that also gives you a score of 4B, which means that invasive coronary angiography is going to be recommended in those cases. All right, so those are the types of questions that you need to be prepared for as far as the exam goes. And then if we have what might look like a total occlusion, right? So there you can consider invasive coronary angiography or a viability study to see if there is viable myocardium there that is worth revascularizing. Okay? So in this case, there's a complete occlusion, but we still see the rest of the right coronary artery. Why is that? Collateral flow, right. And notice that CT is not very good for actually demonstrating the collateral flow because those are very tiny vessels. And that's where invasive coronary angiography is much better because of the resolution, and also you're looking at it in terms of time. As you're filling the vessels, you're actually following the contrast going in. Whereas here, we're only looking at it in one moment in time. So for collateral vessels, definitely invasive coronary angiography, you can see collateral vessels much better than CT. Okay, so then you would put it all together to get to an overall score. Again, I'm not going to test you on the granularity of all this. I've kind of gone over what are the important things, what I think you need to know as far as any fair exam question. If you have a study where there is motion, as in this case, and you cannot evaluate the vessel, then you would put in the modifier N, which means, it's a non-diagnostic study. Unless there is a lesion somewhere else of at least a grade 3, because there you will be recommending functional assessment. So there, you do have some information, even though you're not available to evaluate, in this case, the right coronary artery. So it will still get the modifier N, but still there's a recommendation here, since we have a lesion that requires further evaluation. So this patient would go on then to functional assessment. And then if you have a stent, you're going to mention the stent. In this case, we can see a severe stenosis in the stent, so that gets you a 4A. Okay? And then if there are coronary grafts, right, you evaluate the grafts and you evaluate the vessels distal to the anastomosis. You won't evaluate the vessel proximal, the coronary artery proximal to the anastomosis, because that's why they bypassed it. There's going to be severe disease there anyway. Okay? And then for high-risk plaque, we look for low attenuation, any of these things that we already talked about, positive remodeling, if you happen to have a napkin ring sign. In this case, there's a nice napkin ring sign there too. All right, so know this, know that, what are we supposed to do in terms of the management of these different scores from 0 to 4 in terms of, functional stress up here, stress, and invasive coronary angiography up there. Okay, so if I see this question, what's better for evaluation of coronary artery disease? a coronary CTA, nice beautiful pictures like this, or functional evaluation, stress tests, nukes, etc. And at first, you may have this impression, we're comparing images that look like this to him, all these fuzzy images over here that look like this. So you would think, well, this is no contest, right? Of course, coronary CTA, if you have a really good study, has to be better than any kind of functional evaluation that you're going to do, right? Not so fast. All right. So there was this PROMISE trial that was done a few years back, where they compared coronary CTA with standard functional evaluation, stress test, nuclear medicine, stress echo, etc. 10,000 people in this test. So it was with suspected but undiagnosed coronary artery disease. So they were suspected of having coronary artery disease. They were randomly assigned to coronary CTA versus functional evaluation and follow-up of 2 years. Endpoints were death or any kind of cardiac event. So the better test should have led to a better outcome. And so what happened was, it was kind of disappointing for those promoting coronary CTA, which is the anatomical testing. Remember, we're just looking at the anatomy of the vessel with coronary CTA, compared to functional testing, is that statistically there was no significant difference in terms of the outcome of these patients. And so what did happen is that patients who had coronary CTA had a lower rate of negative cardiac caths, which you would expect, right? Because if you're following, you're kind of sending those patients who have more disease to cardiac cath. So you're eliminating all the negative cases there from cardiac cath. The CTA patients, though, did have a higher rate of invasive coronary angiography and revascularization without a reduction in events, which implies that CTA was finding stenoses that did not affect outcome, the false positive problem. So CT is a lesion on CT is overread as being positive, and that patient goes to cardiac cath, and then that patient results in getting procedures done, which do not affect the overall event rate of what happens to those people. So it seems that CTA was increasing the use of downstream testing. In other words, more people are going to cardiac cath from CT. And so this is where fractional flow reserve, a functional evaluation, may be the gatekeeper, something that is added on to CT to improve the specificity of CT. So the point is that depiction of the anatomy, regardless of the quality of the image, is not enough. In other words, we can say there's an anatomic stenosis here, but the question, is that stenosis hemodynamically significant, right? Just because it looks like a significant stenosis does not mean that it is actually physiologically obstructing the blood flow to a significant degree. So there's a difference between looking at the anatomy, just trying to look at how much stenosis there is, and the physiological implications of that stenosis. And that's where fractional flow reserve comes into play. So in this study that was done in 2007, where they compared medical therapy with coronary intervention, placing stents, etc., there was no difference in terms of the outcome, which again is very disappointing, right? Is that if you treated these patients medically or you treated them with invasive procedures, the invasive procedures did not affect the outcome. So this is where fractional flow reserve comes into play. So what is this fractional flow reserve? What does this mean? So we're trying to evaluate the physiological significance of the stenosis by looking at the perfusion or the amount of flow distal to the stenosis. And they do that when they're doing it invasively, they'll do it by looking at the blood pressure distal to the stenosis, comparing it to the pressure proximal to the stenosis or within the aorta, right? And so it's abnormal if that ratio is less than 0.75 for invasive measurements of fractional flow reserve. So they measure the pressure under conditions of maximal vasodilation. So they give medications for maximal vasodilation. And then they measure the pressure distal to the stenosis, and they compare that to the pressure in the aorta. And if that number is less than this range or less than 0.75, then that indicates that this lesion is physiologically significant, causing a physiologically significant amount of stenosis. That is the principle of fractional flow reserve. And it turned out that when they used this to guide percutaneous intervention, invasive intervention here using cardiac cath, the fractional flow reserve guided cath did improve outcomes as opposed to just looking at the lesion itself anatomically with cardiac cath and looking at the stenosis. So where they did interventions on those lesions that did demonstrate decreased perfusion using measurements of fractional flow reserve, that improved the outcome of those patients. So you want to then concentrate, or you want to use your interventions on those lesions that are really physiologically significant, and fractional flow reserve is a way of identifying those lesions that are physiological. You have a question?
Yeah, so does that mean in the FFR guided group, they
did invasive FFR.
Right, so they found these lesions that you could have seen on angiography if they look at
Right.
anatomic stenotic, and so the ones, I guess the only difference between the two groups is the ones that they saw to be normal function, they didn't do
Right.
anything with. So that's the difference between
Yeah.
the two groups.
So the ones that were not physiologically limited,
They left
they
alone.
left alone. So when you compare anatomic stenosis for these lesions with the fractional flow reserve measurements for these lesions, so that's what we're doing here, and here we're using 0.8. So if the fractional flow reserve is greater than 0.8, then that means that the lesion is not physiologically obstructing the flow. And then, so look at these stenosis, so this is 50 to 70% stenosis, these are lesions of 50 to 70% stenosis, these are lesions 71 to 90% stenosis, and these are lesions of 91 to 99% stenosis. Well, these lesions, 50 to 70% stenosis, 65% of those lesions had fractional flow reserves greater than 0.8, meaning that they were not physiologically obstructing the vessel, even though the stenosis could have been up to 70%. Here, where you have 71 to 90% stenosis, 20% of those lesions still had fractional flow reserves greater than 0.8. So they were not significantly obstructing the vessel. And then, of course, it drops way off when you get up to the very, very severe stenosis of greater than 90%. Okay? So this FFR-guided intervention, when we compare the event rates of medical therapy, remember I showed you earlier there was no difference between medical therapy and invasive therapy for these stenotic lesions. Here, where you compare medical therapy with FFR-guided invasive therapy, and then these are the event rates, so the event rates over time are much higher for medical therapy than they are when you use fractional flow reserve to guide your intervention. Okay, so the fractional flow reserve then is very useful for identifying those lesions that really require therapy. And so how can we do this with CT? Well, it turns out with CT, there are these very fancy computer programs that will take your CT data set and they will construct a 3D flow model from your data set and actually come up with values for the flow reserve as if you did a flow reserve, a fractional flow reserve study based on based on the data from your CT scan. And they'll run this through this very complicated model, and what they do is they give you these very nice images that are color coded. And what's in red here is not good. Okay, so the color coding then will identify lesions with fractional flow, will identify the areas where the fractional flow reserve is below a particular cutoff value, or 0.7 in this case, or 0.8 or 0.75. So it's considered abnormal if it's less than or equal to 0.75, and so that can be color coded in red. So whatever lesions you find on your CT, this is telling you that here in these regions of the right coronary artery and in this region here, the circumflex coronary artery, your fractional flow reserve measurements are good, but here in the more distal anterior descending coronary artery, so here you must have a significant stenosis in this region that is affecting the flow distal to that. And so in addition to the anatomic information you get from your CT, you send out the data set to get these fractional flow reserve measurements, and then you can use this also to guide the recommendations that you would give the physician. This just came out a few months ago, the PRECISE trial where they compared coronary CTA with fractional flow reserve to traditional testing. Remember I showed you earlier when they compared coronary CTA to stress and there was no difference to functional evaluation in patients suspected of having coronary arteries where there was no difference. Well, here, when you use coronary CTA with fractional flow reserve, right, there is a difference, a very significant difference in terms of event rates. So there's a much better results here when the event rates are much less when you do CT with fractional flow reserve compared to traditional testing, where you're just doing stress tests and the usual workup that we've always used. Okay, so that's good news for CT finding. All right, so let's move on now to a different topic. So here's a 35-year-old woman with chest pain and elevated troponin. So of course, what are we worried about? Okay, we're about an infarct. So what's the abnormality on the CT?
Rich.
No, the myocardium's here, right? This is fat. So there seems to be this funny looking area here, right, where it looks like there's something wrong here, right? It doesn't look like a well-defined plaque, right? It doesn't look like a well-defined atherosclerotic obstructive lesion, but there's something wrong here, right? You're not getting good opacification of this vessel. Then here, when you look in cross section, it does look narrow, but hard to decide, what is going on here. Well, let me show you this. So, yeah, so this patient has fibromuscular dysplasia. So what's your diagnosis then? What's wrong with the coronary artery? What am I showing you?
Vasculitis.
No. That's not what I'm showing. This is an acute event. What is this?
Vasoconstriction, like a vasospasm.
Not a vasospasm, no. Dissection. Yeah, this is spontaneous coronary artery dissection. So I wouldn't be surprised if they start showing you this now on the exams. What are going to be the tip-offs? It's going to be a younger woman is going to be the tip-off, right? And you're not going to see coronary artery disease anywhere else. You're not going to see plaques anywhere else or calcifications, and you will see these irregular areas of luminal narrowing. So if you get the history of a younger female with chest pain, elevated troponin, whatever, and you have this irregular narrowing of the coronary artery, right? Start thinking spontaneous coronary artery dissection. Okay? I wouldn't be surprised if they start showing that. So that's the case here. Notice, by the way, it doesn't look like a dissection of the aorta, right? Where you see a flap. So most cases you're not going to see that for spontaneous coronary artery dissections. So it's a dissection of a coronary artery not associated with coronary atherosclerosis or trauma, and it's about a small percentage of patients who present with acute coronary syndrome. This is a common cause of myocardial infarction in pregnancy and in young or middle-aged women. 90% are women between 47 and 53. So if you're given an exam question, woman, chest pain, funny-looking lesion in the coronary artery, start thinking about this, spontaneous coronary artery dissection. Common in pregnancy, 45% of MIs in pregnancy. 70% occur postpartum. Awesome. Okay. So again, if you get the history that the patient was pregnant or recently pregnant, all of these are tip-offs on an exam question that this is what you should be thinking about. 35%, it's responsible for 35% of infarctions in women less than 50 years of age. And it's got a very high association with fibromuscular dysplasia. Okay? So the weakened vessel leads to dissection, downstream ischemia. LAD is the most common vessel, followed by the circumflex, followed by the right coronary artery. Okay? So the theories for this are that, there might be a dissection in the vessel, just like with the aorta, right? Intimal tear, and then you get the dissection. Another theory is that you actually get bleeding out there within the wall that then causes the dissection, but Who knows what the cause is, but these are all precipitating factors: Valsalva, exercise, sex hormones, medications, stress, fibromuscular dysplasia, hypertension. This is a big one: fibromuscular dysplasia, pregnancy. All right. So those are big precipitating factors. There are classifications as to the different types. The type where you can actually see a flap, only about 30% of those you can actually see a flap. So in most cases, you're not going to see a flap. What you're going to see are these areas of irregular stenosis. So type 2, that area of stenosis is greater than 2 millimeters. Type 3, that area of stenosis, regular narrowing, is less than centimeters, actually. Greater than 2 centimeters or less than 2 centimeters. So in most cases, that's what you will see with a spontaneous coronary artery dissection. Okay? And so you look for that luminal stenosis. You might have intramural hematoma. There might be epicardial fat striding. There might be tortuosity. There is no plaque. And it's women usually less than 50 years of age. And then I've given you this also, but these are the important findings. Abrupt luminal stenosis, sometimes tapered. Intramural hematoma you might see. But the dissection flap, usually we don't see the dissection flap. So don't look for the dissection flap when you're trying to make this diagnosis. And then there are these other things that might also be associated with spontaneous coronary artery dissection. Okay? So here there's an intramural hematoma over here that you can see on the cross section. There's an intramural hematoma in this particular case. It's kind of subtle in this case. Although I think if they showed you a case on the exam, it would be an abrupt narrowing of the vessel, is what they would show you. Okay? This one, you can actually see a dissection flap in this case. So this case is unusual where we actually see a dissection flap in that case. Okay? The modality of choice for making the diagnosis is actually invasive coronary angiography, because they will be able to see the features somewhat better than we can on CT. But CT can be used if they suspect recurrence, because recurrence is not uncommon. Up to 25% at 5 years is the recurrence rate for these lesions. Right? So let's talk about MR findings of ischemia and some complications of ischemic heart disease. So we kind of touched on first pass perfusion before. So we do very rapid imaging as you're injecting gadolinium, and we look for enhancement of the myocardium here. So that's a first pass perfusion study. So in this example, the stress is done pharmacologically. So here is and we look at these in short axis. So there's a short axis view, left ventricle, right ventricle. And then here is the stress perfusion view there. So what's the abnormality under stress? Where? Yeah. So there's a reversible perfusion defect along the course of the left anterior, or in the distribution of the left anterior descending coronary artery, right? So it's affecting the interventricular septum there anteriorly. So here you would suspect a significantly obstructing lesion in the LAD, okay? So in this case, so that's a reversible defect. Here we're looking at rest and stress. So what do we see that's abnormal here?
It's like lack of enhancement in the left circle.
So is there a reversible perfusion defect? Do you understand what I mean by reversible perfusion defect? Well, if there's a perfusion defect under stress and it is not present under rest, that is a reversible perfusion defect. That's an indication of ischemia, not infarction, but ischemia. Okay? So is there a reversible perfusion defect?
Yes.
Yes. So you can see along the endocardium, there is. Now, what vascular distribution is that? Well, it seems to be more than one, right? So it looks like LAD and circumflex, right? Maybe something here even more distally, right? So this is and this is where MR can be better than nuclear medicine, because if you're doing nuclear medicine, you know, the signal might drop out, or the activity would drop out kind of diffusely, and it'd be hard to pick up, whereas here we can't see it. So this is multi-vessel disease, and that's the type that can be missed on nuclear medicine studies. So when you're doing perfusion, the right ventricle fills first, and the left ventricle, and then your healthy myocardium enhances, and then infarcted or diseased myocardium or ischemic myocardium perfuses later. Okay. So here's first pass perfusion. This is an MI here along the lateral wall. So if it's a myocardial infarction, you will see the perfusion defect at rest. So that differentiates infarct from ischemia. With ischemia, it will be a reversible perfusion defect. With infarction, that perfusion defect will exist at rest. Okay? So the idea here is that if you have a tight lesion, there's already maximal vasodilation distal to the lesion. So at rest, the perfusion here of the ischemic myocardium will be the same as the perfusion of the normal myocardium. But when you induce vasodilation, or stress the patient, or induce pharmacologic vasodilation, now you dilate the vessels supplying the normal myocardium, but this increases the perfusion then to the normal myocardium, but the ischemic myocardium already is receiving maximal perfusion. It can't increase it anymore. So it is under the stress condition then that you pick up that difference in perfusion between the normal myocardium and the ischemic myocardium. So that is the principle of the stress test, looking for these reversible perfusion defects. And then your vascular territories, you should all be familiar with this, about the different territories on the short axis views for defects and comparing them with the various vessels. Okay? So if we have a reversible defect, then that implies that there is a stenotic lesion there and it's causing ischemia. So it's not an infarct, but it's ischemia if you have a reversible defect. And then here's an example with multi-vessel disease. Okay? All right, so in this patient, what is abnormal? First of all, what kind of studies are we looking at here? What is the pulse sequence? What views?
Steady state.
Yeah, so we're looking at bright blood, cine, imaging. These are steady state free precession. What view is this? Two chamber. This is, and this is a short axis. What's abnormal?
Wall motion.
Where? Where's the wall motion abnormal? Yeah, along the septum and
The
the anterior wall, right? So what do you want to see?
Something to look at the LAD.
You want it right. So you want to see myocardial delayed enhancement. There it is. What's your diagnosis?
LAD distribution.
What?
Acute.
Why do you say acute infarct?
See the, yeah.
You can see the microvascular occlusion, right? So this is an acute infarct in the distribution of the left anterior descending coronary artery. You can see these areas of microvascular obstruction, right? So that was an acute infarct. So what happens with myocardial infarcts is that less than 15 minutes, there's ischemia. The myocardium is not dead yet. But as time progresses, you start to get death of the myocardium, and that infarction wavefront moves from the endocardium to the epicardium. And that's why it's very important in these patients who have chest pain, who present to the emergency room, if they're having an infarct, to revascularize them as soon as possible, because that infarction wavefront is moving over time, and you want to revascularize the heart acutely before much of it gets infarcted here, okay? So we've talked about MR for viability. Normal myocardium, the GAD washes out. If you have infarcted myocardium, the GAD stays. So that's why on myocardial delayed enhancement imaging, you will see these areas of bright signal. Whether it's an acute infarct or whether it's a chronic infarct, both of these will lead to accumulation of gadolinium. So whether it's acute or chronic, scar tissue does enhance. So scar tissue will give you gadolinium enhancement. So this is 3 days after an infarct, this is 6 months after an infarct. Both of those give you delayed enhancement. Okay. So this was the patient we looked at acutely. There's the infarct 6 months later. Notice no more microvascular obstruction, but the delayed enhancement is still there. Okay, so whether it's acute or chronic, you're still going to see the delayed enhancement. Here's another example, acute with microvascular obstruction, and then here, delayed. Well, there's the microvascular obstruction. 6 months later, you can see the whole thing enhances, okay? If I ask you the question, is this patient a candidate for revascularization? The answer yes or no, and how do you determine that?
Yes, because it's not the whole thickness of the myocardium.
Well, there is an infarct, right? You can see that there's delayed enhancement. So there's definitely been an infarct here, but what is the criteria to decide whether the patient is a candidate or not for revascularization? What percentage thickness?
50%.
50 is the number. If there's greater than 50% thickness of infarction, too much myocardium is dead. And so presumably this myocardium is ischemic, and so this patient would be a candidate. Presumably this myocardium is ischemic, and revascularizing it, there's still enough viable myocardium here that it can improve function if you revascularize this myocardium, all right? But if greater than 50% of the myocardial thickness is dead, as we can assess with myocardial delayed enhancement, then too much myocardium is dead. Revascularizing that patient will not result in a significant improvement in cardiac function. So that is why we do viability studies. That is the criteria that you use. You identify the infarct if there is any, and then you have to decide, is it involving less than 50% of the myocardium or more than 50%, because that is the criteria for whether or not the patient is a candidate for revascularization. Right? And if there's an infarct on the first pass image, there will be decreased perfusion, delayed enhancement. Of course, you're going to see the area of infarction. And then we can go through the different distributions of infarct. So what distribution is this? LAD, right? You can see that. This guy, circumflex, right? You can see that. This guy,
RCA.
distal RCA, so this is specifically the distribution of the PDA over here, and then more there's the posterior left ventricular branch over there, so that's a distal RCA. What about this?
No, right, and a left. I was gonna say left dominant.
Yeah, that's correct. So this is
Why
an
is it?
infarct. So this is infarct here along the circumflex, but also involves the posterior wall, right? So this is a left dominant circulation. So this is an infarct in a patient who's left coronary artery dominant. Okay. Okay. So with acute infarctions, we talked about the zone of microvascular obstruction. You can see the areas that enhance. But if you do T2-weighted images, there are also areas that are going to be edematous that do not enhance. Those are areas of risk. Those are areas that if that can go on to infarct. So the edematous areas are the areas at risk. So that will be larger than the area where you see the infarct. So you can see all these areas of bright signal edema. Those are the areas at risk when you have an acute myocardial infarction. They might go on to die, which is why you would consider revascularizing the patient before that occurs if it's an early enough infarct. And the other thing that happens with myocardial infarcts is that the degree of enhancement tends to diminish a little bit over time. So if we look at this acutely, you can see the edema here. When it's acute, goes away. Here, the enhancement, you can see the microvascular obstruction, right? That kind of goes away. And then over here, when you get to the chronic stage, the extent of enhancement will be just a little bit, somewhat less, a little bit less than it is under the acute condition. So, Lamb, what are we looking at here?
So we're looking at a short axis view.
So that's a short axis view, right? Left ventricle. And what's abnormal? First of all, what do we think of the size of the left ventricle?
The lumen looks pretty large.
Yeah, so it looks like it's a little bit, the volume is a little bit increased, and the slide says wall motion. Is there anything abnormal about the wall motion here?
So I think the anterior wall of the left ventricle isn't moving as much.
Right, so the anterior wall here, and also this area, which is the, so that's the, yeah, that's the interventricular septum. So That's not moving as well as you would like. So what is it that we're showing you now?
So, it's a CNA and it's showing that there's.
So these are myocardial delayed enhancement views, okay? Again, in the short axis, and what's abnormal?
So, we see a bright signal in the area of abnormal wall motion,
Right, so what does that mean?
prior infarct,
Yeah, so this is an infarct, and it's in a distribution of what vessel?
that would be the LAD.
Yeah, so this is an infarct in the distribution of the LAD, and you could also, so we could see also on the initial image, notice that there's a little bit of atrophy here in the myocardium, telling you that this is a chronic infarct, okay? So this confirms that we have an infarct in the LAD, which is in the distribution of the LAD accounting for the wall motion abnormality. Now, when we describe wall motion, these are the terms that we use: hyperdynamic, meaning it's more than normal, mild hypokinesis, severe hypokinesis, or akinesis, meaning it's not moving or there's no wall thickening, and dyskinesis if there's paradoxical motion, if the wall actually moves in the opposite direction that you would expect. Now, we can also look at wall motion if you've done retrospective gated cardiac CT. So this is a volume rendered image from a CT looking at the left ventricle. So we can do ventriculograms from CT data also. And then this is an example here of dyskinesia in the distribution of the LAD, is outlined there from a prior LAD infarct. And then here, as we kind of move that around, you can see that this part of the ventricle is not moving well at all towards the apex and the anterior wall. And then this is an example here from CT of akinesia in the distal distribution of the distal RCA, the region of the posterior descending artery. So you can see that along the inferior wall. And then here, as we look here along that inferior wall, that there's a markedly abnormal wall motion, almost, well, there's akinesia there, okay? So we can do the same thing with retrospectively gated cardiac CT. You can also evaluate wall motion. So let's talk about some complications of ischemic heart disease. Yes.
Just had a question on
So, well, it's involving the myocardium, right? But with infarction, it should involve the endocardium. The endocardium should always be involved with an infarction when you have myocardial delayed enhancement. So it is involving the myocardium, but the endocardium always needs to be involved if you're dealing with an infarction, right? Is that clear? This is not full thickness. It's maybe about 75%, but there's a small region of myocardium here that is not enhancing. So it's not a full thickness infarct, okay? All right, now, for this case, so who's over there at Beth Israel who wants to discuss this? What's abnormal here? Let's see if I can. I guess it's not showing up very well. It's not getting good wall motion there, but yeah, they're not moving. So let me see if I can get this to work. No, that doesn't seem to be moving. Anyway, this is showing an aneurysm, a true aneurysm here in the apex of the left ventricle. Okay, and this is usually a sequela of an infarct, usually sequela of an LAD infarct. And another manifestation of that on the plain film can be with these true aneurysms is they can go on to calcify. So we can get calcification there also where you have a true aneurysm. Now for this particular case, we see calcification here in the apex of the left ventricle from a calcified true aneurysm. What's another important finding that's also demonstrated on these images over at Beth Israel? Yeah, so you see this low attenuation, this represents thrombus. So this is a complication of these aneurysms, is that where you have stasis of blood flow, you can develop thrombus there, and so that's a thrombus. So with true ventricular aneurysms, these result from fibrous replacement of infarcted myocardium, most commonly along the anterolateral wall or apex of the left ventricle. They rarely rupture, but stasis of blood in these regions can result in thrombus formation, and of course you will have abnormal wall motion where you have the true aneurysm, usually dyskinesia. And so calcification or bulging in the region of the apex of the ventricle, see on the plain film we can see calcification, is a typical finding associated with these true aneurysms. So other problems are the complications of this, in addition to developing clots, which can result in emboli, arrhythmia can be another complication. And if they get large enough, paradoxical filling of the true aneurysm, instead of the cardiac output going out into the aorta, actually goes into the aneurysm. So that can also be a complication of these true aneurysms. So here's another example where we have calcification here along the apex of the ventricle. Very easy diagnosis here. With the CT, we can see the calcification there from that true aneurysm. So kind of a companion case. So over at Beth Israel, what else do we see here in this case? We can see a little bit of bulging. What else do we see? This is a coronal reformatted image, and this is an image through the upper abdomen. So what does that represent? Yeah, so those are infarcts, and then here a little bit lower down, here within the left ventricle, what do we see here? What does this represent? Well, what's causing these? Yeah, so there's thrombus, and it's actually partially calcified. So when you have chronic thrombus, it can go on to calcify. So this is chronic thrombus here within this true aneurysm, and a complication of this are these embolic infarcts that have occurred there within the kidneys. And then here's some volume rendered images showing you the calcification, and then these are the infarcted regions there of the kidneys, okay? All right, so Lamb, this person shows up in the emergency room, short of breath. The chest x-ray looks like that on the left, and they get a CT scan for pulmonary embolism because they're short of breath. So first, what's abnormal on the chest radiograph?
It's very whited out near the lung bases,
Yeah, and it turns out that that represents what?
very large pleural effusion.
Yeah, so there are large pleural effusions. Now there's these areas of atelectasis also that are contributing to the opacity. So is there another abnormality you see on the CT?
The interventricular septum, there's a little bulging into the left.
Well, that's okay, that's normal, but when you look at the myocardium of the left ventricle, do you notice anything?
There's that little hypoattenuating area.
Yes, so here along the endocardium of the left ventricle, towards the apex especially, there's this area that is not enhancing as much as the rest of the ventricle. So what do you think is going on in this patient? Patient shows up with chest pain, short of breath, bilateral effusions, and this. So this patient's in congestive failure, but what is causing the failure? What is this stuff?
Is that fatty replacement?
Well, not yet.
Not yet.
This is an acute presentation, so this is acute infarction.
It is, okay.
Yeah, so this is an area of hypoperfusion in this patient who's having an acute infarction. And so sometimes you can actually pick up that on a CT scan. We can see that area of endocardial decreased perfusion in this patient who's having an acute infarction. And 3 days later, came back for another CT, and it shows this finding. So what is the finding here that we have 3 days later?
So now we see this filling defect in the left ventricle.
Yeah, so now we see this filling defect here in the apex of the ventricle, and what does that represent?
So that's thrombus.
That is thrombus, right, which is again a complication. So this patient has developed this aneurysm here in the ventricle, and because of the limited wall motion, you get stasis of blood, and the patient has developed a thrombus there. in the apex of the ventricle, okay? So over at Beth Israel, here's another patient who also has a history of a recent myocardial infarction. What's abnormal here on the chest radiograph? Okay, and then you see it on the lateral view? So this area of bulging here, do you see it on the lateral view? Well, yeah, the left atrium's up here though, but this region of bulging, where's that region of bulging? No, it's back here. See it? Okay. So now what are you concerned about here in a patient who has a history of recent myocardial infarction, who has bulging extending from the posterior region? Also, patient has a pleural effusion, but now we have bulging from the posterior aspect of the left ventricle in a patient with a recent history of myocardial infarct. So here's the CT on this case. What do you see? So is this a true aneurysm or a false aneurysm, and how do you know? So how do your colleagues know? Well, what is it that is containing the aneurysm? What is this? Yeah, it's contained by pericardium. Notice the myocardium. Here's the myocardium here, right? So a false aneurysm then represents a contained perforation of the myocardium as a complication of a myocardial infarct again. And this is contained by pericardium. So what's the treatment for this? No, probably the last thing you want to do. Surgery is the treatment, right? Because the complication here is rupture, right? Pericardium rupture, the patient will have a hemorrhage and will bleed to death. Okay, so the treatment for a false aneurysm is surgery, right? So you need to fix that false aneurysm. Now it turns out that the best way to differentiate a true aneurysm from a false aneurysm on imaging, what's the best way to differentiate a true aneurysm from a false aneurysm? Your colleagues know? Yes. So what about the mouth of the aneurysm or the neck of the aneurysm? With? Yes. So with a false aneurysm, you have a narrow mouth. With a true aneurysm, you have a wide mouth. So here you can't even see the mouth, the neck of the aneurysm. So on imaging studies, that's what we usually rely on. We try to evaluate the mouth of the aneurysm. True aneurysms are associated with a wide mouth, and false aneurysms are associated with a narrow neck. So these false aneurysms usually involve the posterior wall of the ventricle, and they can involve the diaphragmatic wall. Also, these require surgery. Again, it's the ostium. If the ostium is less than 1/2 the diameter of the widest part of the aneurysm, then you would be concerned about a false left ventricular aneurysm. So whenever you have a history of myocardial infarction and you have this bulging from the posterior aspect of the heart, then you will be concerned about a false aneurysm. Here's another example on MR. You can see that all of this is blood pool that is being contained here by pericardium, that there's a perforation there within the myocardium. So a false aneurysm is a contained myocardial perforation, okay? So here's our next case. This is a 47-year-old woman with heart failure after recent myocardial infarction. Lam, do you notice anything here? What kind of view is this, by the way?
This is a four-chamber.
It's not a four-chamber view.
Oh, it's a left ventricular outflow.
Yeah, it's a left ventricular outflow tract view. So this chamber is
That would be the left atrium.
this one,
Left ventricle.
and this is,
The aortic
right, this guy over here,
right ventricle.
that's the right ventricle, right? So it's a left ventricular outflow tract view. So when we look at the size of the chambers, what do we think of the size of the left atrium?
That's pretty big.
Looks big, size of the left ventricle,
Also sort of.
also kind of big, right? Now, do you see anything that might explain why the patient is in heart failure acutely after a myocardial infarction?
Papillary muscles?
Okay, so this here, what are we pointing to here?
The mitral valve.
That's the mitral valve. What is this guy here?
It looks like a vegetation or something.
Well, you might be concerned about a vegetation, right? That's not a bad choice. But what is this here? What this structure could be what?
So that's supposed to be the chordae tendineae, right?
This is chordae tendineae here,
Oh,
and what is the
okay.
chordae tendineae attached to?
So it's disrupting the papillary muscle.
Papillary muscle, right? So this is a papillary muscle rupture, right? So this portion of the papillary muscle here is kind of floating around attached to the chordae tendineae. That's a papillary muscle rupture, and the complication of acute papillary muscle rupture in association with MI, what is that cause that results in failure? That causes what? So if the papillary muscle ruptures, what happens to the mitral valve?
There's incontinence.
Yes, so the patient develops acute mitral regurgitation that is not well tolerated. And so then the patient goes into failure. So a cause of failure after acute myocardial infarction could be rupture of the papillary muscle because it causes then mitral regurgitation. And then the chest radiograph, often in these cases, might show asymmetric pulmonary edema, especially worse on the right side, especially more severe in the right upper lobe, because the jet of the mitral regurgitation can be directed towards the right upper lobe pulmonary vein. And so that then can cause this asymmetric pulmonary edema, especially consolidation like that in the right upper lobe. So over at Beth Israel, what are the arrows pointing to? Name the structures. Which ones? They have, what do you call these? These are called, so this one, it's not so hard, anterior, and this one is posterior, right? So that'd be the anterolateral and posterior medial papillary muscle. Now, which one is most likely to rupture after myocardial infarction and why? Which one is more likely to rupture? Because? Yeah, so the anterolateral can have a dual blood supply from the LAD and the circumflex. So it's the posterior medial one that's usually supplied by the distal right coronary artery. Okay, so that is the one that is more likely to rupture as a complication of myocardial infarction. Okay, so rupture of the papillary muscle. This can occur within 5 days of MI, and most commonly involves the posterior medial papillary muscle. Because it's supplied by the PDA or the right coronary artery. And as we talked about, the anterolateral one often has a dual blood supply. And then this asymmetric pulmonary edema in a patient who has a history of recent myocardial infarction, especially pulmonary edema like that in the right upper lobe or consolidation in the right upper lobe, can be an indication of rupture of the papillary muscle. So here's a patient also who has dilated left ventricle, very bad wall motion, so hypokinesis, dilated left atrium. And then here there's a little bit of mitral valve regurgitation. And in this case, this is another complication of, can be from failure and ischemia. And this is an example of papillary muscle dysfunction. So this can also be associated with myocardial infarction. The infarction can also involve the papillary muscles themselves. And so dysfunction of the papillary muscle can also result in mitral regurgitation here. All right, so that's papillary muscle dysfunction. So again, usually the posterior medial papillary muscle that can result in papillary muscle dysfunction and mitral regurg. This was a woman who had a recent myocardial infarction, has this asymmetric pulmonary edema here on the right side, as we see there. In this case, you could see the severe mitral regurgitation. And in this case, it wasn't rupture of the papillary muscle, but this was papillary muscle dysfunction as a complication of myocardial infarction. So as a complication of infarction, both papillary muscle dysfunction and papillary muscle rupture can result in mitral regurgitation and exacerbation of congestive failure. Okay, Lamb, this patient has a history of myocardial infarction 1 week ago. What kind of view is this? That's a 4-chamber view, and what kind of view is this? Short axis, not a two chamber, but a short axis view, right. So anything abnormal?
There's a clear disruption in the interventricular septum.
Right, so you can see that there's communication here across the interventricular septum. So this is rupture of the interventricular septum. This is another complication of acute myocardial infarction, and this also results in failure, exacerbation of heart failure after infarct. The shunt component is really not the part that's symptomatic. What happens is the patients go into failure, so with rupture of the interventricular septum. So usually occurs within 1 week of infarct. It's pretty unusual and usually involves the muscular septum near the apex, the LAD territory. Most of these patients also have a left ventricular aneurysm because of the involvement of the LAD, and the mortality rate is quite high in these cases. So a new systolic murmur after myocardial infarction or onset of biventricular failure after myocardial infarction. So that can be an indication of rupture of the interventricular septum, okay? So you can have, usually it's the findings of the CHF that overshadow the findings of the left to right shunt in these cases. So the patients will go into congestive heart failure when this occurs, rupture of the interventricular septum, all right? So that's a discussion of our complications of ischemic heart disease.